I'm Dr. Edina Komlodi-Pasztor, Director of Neuro-Oncology at MedStar Georgetown University Hospital. I see patients with CNS tumors, which means that the patient has cancerous growth either in the brain, in the spinal cord, or the lining of the central nervous system, or somewhere in the peripheral nerves. The treatment plan based on basically two things. One is the diagnosis we have that we learn from surgery, pathology, or just by imaging. And the other part comes from patient preference. Our philosophy is to educate the patients about the treatment options and then individualize it per patient preference. So brain tumors are complex, and brain tumors require complex care. One physician cannot take care of a patient with brain tumor. It requires a team. MedStar Georgetown provides this team. The team works together. The team is able to move quickly if needed. Our team includes multiple specialists. We have neuropathologists who can take a look at the sample, make sure that we got the correct diagnosis. We have neuroradiologists who help us interpret the images. We have neurosurgeons with great experiences. We have radiation oncologists. We have neuro-oncologists, and we have so many other specialties that play a key role in the treatment and management of patients with brain tumors. So I think right now this is a really exciting time in neuro-oncology. In recent years, we learned so much about the basic biology of brain tumors and different CNS cancers. Now we have the knowledge, the molecular basis, and now we can work on to find out what is the solution, how we can cure and treat these different types of cancers. We have a lot of exciting drugs in the pipelines. We have a lot of exciting clinical research and even basic research that in the next few years and decades will lead to real improvement in how we treat the patients with brain tumors. With my patients, I meet them frequently. Some of them come to see me weekly during treatment phase, and we form special connections. We learn so much about each other. I learn about their grandchildren. I learn about their dog. So we really have special bonds. I get to know them really well, and friendship develop, and we become sort of like family to each other. And this is just so satisfying to meet them every week, and I'm just looking forward to see them, help them, and walk the journey with them. Neuro-oncologist is a physician who is trained to diagnose and treat patients with CNS tumors, which includes tumors in the brain, in the spinal cord, the lining of the nervous system, or in the peripheral nerves. And neuro-oncologists work together with multiple other physicians from different specialties, including neuropathologists, neuroradiologists, neurosurgeons, and radiation oncologists. Some of the patients don't experience any symptoms. They get imaging done for another reason, and the imaging reveals a brain tumor, and maybe they never had any symptoms from it. Other patients may experience some non-specific symptoms like headache, nausea, vomiting that gets progressively worse. And sometimes patients experience specific neurological deficits. For example, they are not able to speak, they have weakness or numbness. That means that if a brain tumor grows in a specific location of the brain, that region of the brain will not function. So if we have a tumor in the area where our speech center is, that patient probably notices that she or he cannot speak correctly. If you have any of these symptoms, it doesn't mean that you have a brain tumor, But if you have symptoms that are getting progressively worse and they are not resolving, you are better to speak with your provider and get the proper evaluation that is needed. CNS tumors can be divided in multiple different ways. So usually we talk about CNS tumors if there is a cancerous growth somewhere in the central nervous system, which includes the brain and the spinal cord or the lining of it. We can distinguish between the origin of the tumor, whether it is coming from somewhere else of the body, for example, we have a metastatic lesion, or whether the cells are originating from the central nervous system, like a brain tumor or spinal tumor. We can also divide growth based on the biology. We can distinguish whether a lesion is benign or malignant. So if we find a lesion in the brain or in the spine, the first thing we need to figure out what is the origin of that lesion, whether it is coming from somewhere else in the body. So let's say that there is a cancer in the body, in the lungs, in the breast, in the kidney, and that cancer spread to the brain, or whether that lesion is originating from the brain tissue or CNS tissue itself. So once we find that we have a primary brain tumor, we need to see whether it is benign or malignant. Usually these patients meet with a neurosurgeon. A piece of the tumor will be taken for pathology diagnosis. Often these patients meet with a neurosurgeon who will talk about surgical options for this lesion. Surgery can have two roles. One, to take a piece from the tumor and analyze it under the microscope and send the tissue for further molecular analysis. The other reason why we have these surgeries to hopefully take the entire tumor from the brain. In brain tumors, we grade the tumors. Again, we grade them from grade 1 to grade 4. Grade 1 means that the lesion is not growing fast. Grade 4 means that the lesion probably is growing fast or have poor outcome. Every brain tumor has its own grading system, and not all brain tumors have the entire spectrum of grades from 1 to 4. This grading usually represents the histological aggressiveness and behavior of the tumor, but does not necessarily correlate with the overall progression we know today. For example, medulloblastoma is a WHO grade 4 tumor, but a special type of medulloblastoma, the Wnt-activated medulloblastoma, has more than a 90% 5-year survival with today's treatment options. Histologically, the diagnosis of brain tumors are based on histology. Histology means that we take a piece of the tumor, we send it to pathology, the pathologist stains the tumor tissue, puts it under the microscope, and we take a look. We describe what we see, and often what we see corresponds with a diagnosis. In recent years, we had a great advancement in the molecular understanding of brain tumors. We learned that certain molecular markers are associated with certain types of brain tumors. Based on our new brain tumor classification system, we need to take a look at the histology, but we need to also get information of the molecular background and landscape of the brain tumor. And we need to put together these two and provide a so-called integrated diagnosis to the patient. So some patients don't need any treatment. Depending what we see on the imaging, if it is reassuring and we think that this is a low-grade benign lesion, we might just offer the patient to wait and watch, and we see the patients periodically in a couple of months with a new MRI. In other cases, we recommend treatment options for the patients, which may include surgery, radiation treatment, and chemotherapy. We do surgery for two reasons. One, to get a tissue diagnosis. The other is to remove the lesion entirely if it is possible and safe. Some patients need radiation treatment, which will be followed by chemotherapy, and other patients may receive radiation treatment with chemotherapy, then we call it concomitant chemoradiation. And these patients often get additional chemotherapy, which is called adjuvant treatment. For example, in glioblastoma, which is the most common type of malignant brain tumor, we usually do surgery and with the goal of maximal safe resection, followed by concomitant chemoradiation and adjuvant chemotherapy. So with the concomitant chemoradiation, the patient usually gets a 6-week-long treatment of radiation. The radiation goes from Monday to Friday, and the patient rests during the weekend. During this time, these patients take an oral chemotherapy called temozolomide. They start the oral chemotherapy on the first day of radiation, and they continue to take it every day, including the weekends, till the end of radiation. Following the concomitant chemoradiation phase, the patients get a 4-week break. Then we continue the treatment with the adjuvant chemotherapy phase, which is temozolomide alone, but this time we give it at a higher dose. During the adjuvant phase, which is usually 6 cycles, the patient takes the drug for 5 days, and then we have 23 days off. This 28-day long period is called 1 cycle, and then we repeat it 5 more times. Most frequently, we use temozolomide as our chemotherapy. That's a great option. This is an oral pill, so the patient is able to take home the medication and take it at home on his or her own. It does not require an IV line. The patient doesn't need to come to the hospital to get the treatment done. Temozolomide is usually really well tolerated by the patients. It doesn't cause hair loss, but it does have some side effects, which are usually very well managed. Temozolomide may cause nausea, but we have very good medications to help the patients with nausea, so it's usually not a problem. Temozolomide may also affect the blood count. The white blood cell count can go down and the platelet count can go down. So while the patient is on temozolomide, we're going to continue and follow the blood counts by weekly blood draws. Some of the patients may develop constipation during the treatment. Again, we have great over-the-counter medications to help with this side effect. Brain tumors are really complex. So one physician cannot solve the problem and cannot provide all of the treatment that patients need with a brain tumor. Really, a patient needs to select a team of experts who are working together, who are collaborating together, and who create a plan that is the best fit for the patient and mirrors the preferences of the patients. At MedStar Georgetown University Hospital, we have a line of expertise who don't do anything else but treating patients with brain tumors. We have neuropathologists who got extra training just looking at brain tumor tissue in order to come up with the most appropriate and the most accurate diagnosis for our patients with brain tumors. We have neuroradiologists who help us understand the images and sometimes even suggest different methods of techniques what we can use to better understand the imaging. We also have neurosurgeons, we have radiation oncologists and neuro-oncologists. We are fortunate to have all of the support system from Lombardy Comprehensive Cancer Centers. We have dietitians, we have psychosocial support, we have geneticists who can help our families. As a big academic center, we're also fortunate to have multiple other specialties within the hospital. For example, within neurology, we have epileptologists who are able to take care of our patients with complex seizures. We have neuro-ophthalmologists who can help us when patients have some eye symptoms related to the brain tumor. In recent years, we learned so much about the molecular markers of brain tumors, and we know that some of the markers may represent a more aggressive course of the tumor. As a result, a biomarker may influence the grading of a brain tumor. So our goal is to provide a state-of-the-art treatment plan for every patient who walks in to our center. The treatment plan is put together by multiple different physicians and specialties. On our tumor board meetings, we have 15 to 20 physicians who come together. These include neuropathologists, radiation oncologists, radiologists, neurosurgeons, neuro-oncologists, and medical oncologists. We review every case, we review the slides of the tumor, we review the imaging, and after we get the diagnosis, we put together treatment options that will be presented to the patient. Our patients have the opportunity to participate in multidisciplinary visits. That means that the patient has one appointment, and on that appointment, he or she meets with multiple different physicians. For example, we have multidisciplinary visits together with neurosurgery and neuro-oncology, but some patients may need more than 2 specialties. In those cases, the patient meets the neurosurgeon, the radiation oncologist, and neuro-oncologist in the same visit at the same time in the same room. Getting a diagnosis of brain tumor is very challenging and scary time. So when you have the diagnosis of a brain tumor, you don't necessarily able to think or figure out how the healthcare system works and who are the physicians you need to see. You need a lot of specialties to work together. You need a neurosurgeon, you need a radiation oncologist, you need a medical or neuro-oncologist. Finding them in different institutions is just very challenging. Here at MedStar Georgetown University Hospital, we are here to provide comprehensive care to our patients. When a patient calls us, we set the patient up in our multidisciplinary visit when the patient will meet with neurosurgery, radiation oncology, and neuro-oncology at the same time. We have our patients schedule their MRIs. We have them to meet with other supportive providers. For example, if they are interested in dietary changes, we have a dietitian to meet with them. So we are here to provide and help them through the entire journey. Our job is figure out where we are and what are the options, where we're gonna go from here. Our job is to arrange all of the visits, make sure that the patient has all specialties that they need to get better. My job and our job is to worry about all the logistics and figure out what is the best treatment option for the patient. So the patient will be able to focus on the most important thing, which is getting better.